Thank you very much for this invitation, and I'm pleasured to be here with you and have this presentation to you about workplace-based assessment. In fact, this presentation will be of interest to the teachers or supervisors, clinical supervisors, as well as for the students or the residents, simply because it's newly introduced, and I think everybody will be keen to know what is the proper way of implementing workplace-based assessment and why it should be implemented and how can be utilized for the good of the improvement of the residents training program. So we'll talk about, I don't like to be tight behind this. So we'll talk about background about workplace-based assessment, then we'll talk about its validity, reliability, and we'll go through different types of workplace-based assessment. I read your blueprint for assessment, the new one that has been designed, and I asked the secretary to distribute it on all of you. So if you have any question about anything, please interrupt me. I don't mind. And then we can answer it one by one, because I think to clear the idea about how you will utilize this is more important than the theoretical background, if any, or if I will go through it. The second reason I'm telling you this, I usually, when I present this, whenever I present any tool for workplace-based assessment to follow, there will be a practical session. But 1 hour will not allow me to do this. So the only way to clarify things for you is to ask. I don't mind. Just keep on asking. So historically, assessment used to be tight in one place and very structured, and people go into a small hall where paper will be distributed and everyone will cognitively reflect whatever he memorized on this paper, and then marks will be given. It's not anymore, because simply the new era of medical education, we want to know how residents or how healthcare professionals will be able to practice in the real life. And this is really what we call educational outcome, and that's what we should focus on in any education. And that's why workplace-based assessment came into the field of medical education. The Millers came and started to structure how we should look into student assessment. Is it only competencies? No, it's not only competencies. There are several structures of things that we need to assess. These are knowledge. And then competence. The student or the resident needs to know how to do things before they really describe how to do it, which is performance, and before they do it in real life. So we move from knowledge only into simulation, where they can reflect what they have learned on a simulation, and into the real field or into real life practice of their taught information or skill. So the action focus on what occurs in practice rather than what happens in artificial testing situation. And this what usually reflects how the resident or how the healthcare provider or physician will do in the future. And that because we are looking for this, assessment became really difficult, because it moved from a controlled situation and into very uncontrolled situation. It moved from exam room into open field. It can be ER, it can be OR, it can be in the ward, it can be in the clinic. So you have to assess the resident everywhere, because they will not be practicing only ER or OR. They will be practicing everywhere. So you have to assess them wherever they are supposed to practice in the future. And that's the difficulty of workplace-based assessment. In workplace-based assessment, we do assess does. So it's not the knowledge, it's not do they know how to perform or even perform it on a simulation. We assess a real life performance, and then so we are assessing really behavior rather than the cognition, but they will not be able to do this without the theoretical background, of course. And we assess their performance or hand skills. So this is mainly workplace-based assessment. So what's your understanding about workplace-based assessment from the resident side? Ibrahim? So basically, what you have mentioned is, to some extent, is part of workplace-based assessment, but there are certain things that will make it workplace-based assessment and not a short case. Because when you describe this, those from my generation or around my generation will think, so what's the difference between this and short case? We used to have short cases. What is the difference? And we'll go now into the various types of workplace-based assessment and what is the difference between workplace-based assessment and that traditional type of evaluation and why we are doing this. So what do we stress on workplace-based assessment? We stress mainly on assessing healthcare provider or residents across the domains. So we don't take one aspect of the information or the skills. We take the different aspect of it. We assess them across examiners. So it's not only one examiner who will assess one resident on one case or one medical disorder and then decide whether this resident will pass or fail. No. There will be multiple attempts of exam that reflects sampling of all the curriculum so that we can know that this resident deserves this mark or not. Or the aggregation of these marks will be more reliable. So do you think, in your opinion, that if the resident will perform in front of you on real patient, he will be able to perform it similar way in a real life situation? Teachers, supervisors? Okay, so at least it's a better predictor. In fact, literature says yes, it is reliable and it is valid simply because you are sampling more and you are exposing these residents to more tests and more sampling of your curriculum. And it's not only you are assessing, maybe you are a very difficult examiner, but he is softer, she is medium between both of you. So you might give very low mark, but he will give average mark and she will give high mark, and the aggregation of this across the time will give really the correct performance of the student. And this is the thing that will that increases the validity and reliability. So if we reflect on your definition, it's not only one occasion. So if we will implement workplace-based assessment, it has to be multiple occasions. Whatever that tool is, one event doesn't make any reliability. Whatever that tool is perfect or the best tool in the world, and you are the best examiner in the world, and you are the best resident in the world, again, the mark will not be reliable. So it has to be multiple longitudinal attempts. So we are assessing in real clinical condition with multiple assessment events, multiple examiners, and multiple domains. That's what will give workplace-based assessment a real high validity and reliability. Without this, yes, we are implementing workplace-based assessment, but as if we are training on how to do it. But we are not really assessing reliably. And we are wasting the resources for no good reason. Another thing that will make workplace-based assessment a real one is giving feedback. Even if you are utilizing it to give mark, to pass and fail the students, you have to give a constructive feedback. So anyone who is implementing workplace-based assessment, he should be trained as a supervisor on how to give constructive feedback, because the student has to use this feedback to improve on himself, and then he will review that performance later on, find out whether that student has covered or that resident has covered the gap in his performance or not. So this is another rigor of workplace-based assessment. So talking about reliability, this is the example. I'm obstetrician by training, so my examples all are obstetrics, which is far from your things. But whatever the case, whatever the scenario, if one student is tested by 2 examiners over 1 hour time, talking about effect of diabetes on the vision or whatever thing you want to talk about, and we take the same 1 hour, but we give the resident to be examined by 4 different examiners on 4 different topics in 4 different domains, ER, OR, clinic, maybe in the wards, and then we assess him. Which 1 hour will be more predictive of this resident performance? The B, which is the multiple events, multiple examinations, multiple domains, that will give us better idea about the performance of that resident. So what make our performance as evaluator good is not 1 event, not 2, not 3. What is the acceptable reliability for any exam? 0.7 above. So anything 0.7 above is acceptable. And do everybody know what is reliability? Reliability? What do you mean by reliability? Reliability, this is validity. Reliability means that if I will test the similar students within the same topic, they are likely to score a similar mark. So if I do a test and it's highly reliable, it reflects the performance of that residence across. And what's validity? We are testing what should be tested. So we are sampling across the curriculum. So this is validity and reliability. And any test, if it is really reliable, it is usually valid, because it reflects that we have sampled across all the curriculum. So you'll hear reliability and validity a lot. And to make any test reliable, there is a correlation between reliability and the time of the test performance. So, and that's why people moved from long case to short case in the past. And now they are moving into other type of tests. Why? Because if I will do a long case that will take like half an hour or 1 hour, and I want it to be reliable, then I have to go for multiple ones, then I have to go for 7, 8 hours of test to reach real reliability. But in work-based test assessment, because we modify our examination into 15, maximum 30 minutes, so we can do multiple tests, and that will make it practical. So we can reach a reliability of like 0.8 with a test of like maybe 5 hours or 7 hours. So if we distribute this across all the year, then maybe that's something doable. This is one method, and it's utilized in your blueprint about workplace-based assessment. So we can see that with 1 hour, we reached only 0.7. With 2 hours, we reached 0.8. With 4 hours, we reached 0.9. With 8 hours, we reached 0.9. So if you are the one to decide how many hours you're allowed, do we need really to go to 0.9? Sorry. As examiners, do we need really to go to 0.9 while 0.7 or 0.8 will give us more or less similar effect? So like maybe 2 hours of examination for mini CX will make it okay. and we can design our assessment plan this way. Why I put this slide? Because I noticed that you did not mention in your blueprint, when I read your assessment, how many events of mini CX you'll do. There is mini CX, there is case-based discussion, there is portfolio, there is in-training evaluation form, there is preparatory course, and there is after that in year 3 another course, and there is final exams and MCQs and oral exams. So everything you have more or less. But for workplace-based assessment, you did not mention how many you will do in every and each rotation. What is the frequency, and how this will be booked for the students, and the way the students will be marked, and who should be giving the feedback. These things has to be really decided for the students. But implementing workplace-based assessment reflects very good educational impact, and it reflects on the students' practice in the future. So this is something really good to be done. There are 3 types or 3 occasions that you can implement, or 3 ways you can implement workplace-based assessment, and you have it all in your assessment. That's why I mentioned. You have the direct performance measure of single event, like mini clinical evaluation exam, case-based discussion, which in your curriculum. There is longitudinal performance measure, like in-training evaluation, and you have it by the end of each rotation. And there is the aggregation method, like portfolio and logbook, and I noticed that you have both. You have them both. So we'll go through this. Any question before I continue? Okay. We'll talk about mini clinical evaluation exam. Mini clinical evaluation exam, for those from my age, it's very similar to a short case. What are the differences? So the student will know that he will be assessed on that certain day, for example, or during that certain rotation. He will be assigned to one patient, and he will be asked to do a very specific task. It's not a general task, examine the patient, no. He needs to know exactly what is the thing that he needs to be to do, and then he will be observed while doing that. In short case, we were not observed. We'll go to the patient, we'll do our examination, and come to discuss it with our examiner. But here, the examiner has to see the student or the resident while he is performing. This is one thing. After that, that should not take like 10, 15 minutes maximum. A discussion on his performance will occur, ending by constructive feedback, and maybe plan how to improve on his performance. And that's the mini clinical evaluation exam. Whether this will end up by giving mark or without giving mark, it doesn't matter. The most important thing is that the student or the resident will get feedback. He will know, and he should see how much he scored, and he will sign even the evaluation form. So no problem if he will know his mark. What can you assess? You can assess everything. How to take history, this is one assessment method. Doing physical examination, his professionalism, for example, in breaking bad news or breaking a news, his clinical judgment, his counseling skills. You can assess anything. Any direct contact skills that you would like your student or your resident to obtain can be assessed by mini clinical evaluation, but it has to be very brief, focused, ending by constructive feedback, and you should observe the resident while he is performing. This is our form in our university, but I saw that you have a form, and by the end of the form, as if there is even like a logbook or numbers that needs to be done, but it doesn't change anything. You are assessing certain skills, certain aspects of the resident, and then you are scoring according to this. And the good thing about your form, there is a description about every and each mark. So there is a description for the examiner telling him what is the criteria to give that mark. And this is really good. And if you feel that any of the items is not really relating to the task that you gave to your resident, just write not applicable, and that will be calculated accordingly. So don't mark something that the student or the resident did not do. And as we can see, it's reliable, but you need to decide how many times it will be done in every and each rotation, in a practical way that you can implement it. So usually we decide it also depending on the manpower, the logistics, because it requires time. It takes time. You have in your curriculum also case-based discussion, very similar to mini clinical evaluation, but it has differences is that you don't need to get the student or the resident to be face-to-face with the patient. He might be face-to-face with patient data, like giving him an X-ray or whatever photo or whatever lab results about the patient, and then starting discussing the case and reflecting on the management. One way of doing it. If you have ER, and you have OR, and there is OR emergency OR list, you can ask the resident to classify which patient should go to the emergency room first or to the emergency OR room first, depend on the severity, and he should be able to say why. There are so many examples about case-based discussion, so it's a discussion of patient data, results, X-rays, anything. But it will be done the same way. It should not take more than 10 to 15 minutes. It has to be very focused, and it should end by giving constructive feedback to the resident. The challenge is not only in case-based discussion, but in all workplace-based assessment is the correct implementation and the standardization across all the residents. But what sort out our standardization, and the resident needs to know this very well, and nobody should feel bad about difficult case, is that you will not be exposed to the same case always, and your mark will be coming aggregated across all the cases that you will face. So maybe this time you got a difficult case, the next time average case, the third time easy case, because your examiner cannot guarantee who is coming to the ER today. So whoever comes to the ER, this is your chance, but it's very unlikely that your chance will be bad always. So randomly, with different examiner and different cases, you are likely to have your really reliable mark. In longitudinal performance measure or in training evaluation, multi-source feedback. Multi-source feedback is really a good method, but it's not implemented in your curriculum. Let's talk about in training evaluation. What do you think, residents, about in-training evaluation? They like it? They don't like it? Do you think it's fair? No comment mean negative. Okay. Again, let's talk literature-wise. The in-training evaluation, it depends on, it will become valid not in one rotation. It will become valid across all the rotations. Again, the same principle that we said in many clinical evaluation exam and in case-based discussion. So your in-training evaluation will reflect every aspect in you, and your in-training evaluation is based on CANMET. So they are assessing everything in you, through direct observation of your practical skills across all the rotation or the attachment that you are in. So it's likely to reflect your performance, but not in one time. Once you end up all your programs, so the aggregation of all your in-training evaluation, it's likely really to reflect, because the form is well designed and it's very well structured, so it contains everything. It's with you in your handout. So in-training evaluation, literature-wise, has proved to be valid and reliable if the form that has been implemented is really well structured, and it covers all the knowledge and the skills that are supposed to be assessed. So if we prove that the form has included everything, then the aggregation of your assessment should be fair. Whether you got it high this time and low that time, but the overall performance is likely to be valid and reliable. Again, by the end of your last year, there is portfolio, but I don't know how you will implement this portfolio. Yes? Uh-huh. So it's a logbook. Yeah. Logbook is part of your form, but this is what you have described as logbook, that there is a minimum number of every and each case that you have to perform, and this has to be supervised, and somebody signed that, yes, you have done this number of laser, this number of whatever, and then by the end of the way, yes, you have completed the requirement. This is logbook, and it's required, and it's really good and needed. At least there is a way of measuring the resident's performance. But portfolio, it's an aggregation of information that demonstrates competence, and these aggregation are supervised in a way that continuously there is somebody who is reviewing this aggregation and giving a reflection to the residents on their performance and where are the gaps and how they have to do on this. So doing the portfolio by the last year where you are graduating is not going to reflect, maybe it will reflect what did you do, but it will not give you a chance to improve. So if we are doing portfolio, it has to start from year one, and there should be somebody assigned to review this portfolio. And this is the real difficulty of portfolio. First, it's a big amount of, you have described it this way, big amount of papers that you have to do it. People now tend to do it electronically. So, and there should be a method of communication with someone who is monitoring this to be a portfolio. But the other way, it's an aggregation, but it's a logbook. So I didn't really find the description, but I think I said maybe I can describe only the differences, and it's up to you the way you implement it. And we can use a portfolio for so many things. You can use it to assess. In some of the universities and colleges, they use it to pass and fail based on the portfolio, the aggregated performance, counseling, mentoring, coaching, everything. The disadvantage of portfolio, very difficult to collect the data, very difficult to find people who are enough to give reflection on every aspect of the students or the resident performance across the year and monitor their performance and give them feedback. So it's time consuming, but the beauty of it, that it's very good method to improve, to enhance performance. So it should be used with strong educational concept. It's not just aggregation of paper. There should be a reason why we are aggregating these papers. And there should be a presence of immediate learning value for the learner, so he can be interested in collecting these papers, and needs to be back and forth with the resident so that he knows where to improve, what to enhance. So in conclusion, workplace-based assessment is really a good method for resident evaluation and student healthcare worker evaluation in general. It is used to assess practice in real life. It reflects performance in real life after graduation, and it reflects the fulfillment of the educational impact that you are looking for from your teaching program. And it's now open for discussion or questions. Yes.
Thank you for this great lectures. Actually, we're starting to apply this new curriculum which I think you saw. That's just this year. So most of this were introduced in the training from the beginning of that last October. So really it's come to give us more details about it, will help us even though to apply it regarding to the many types of evaluations, examination that applied. And if you looked for our curriculum, there is a lot of exams starting from first day, and now starting to introduce the new basis for the evaluation, rather just only to go for the just only multiple choice exams or even OSCEs or the difficulty how to introduce it, how to apply it, especially in ophthalmology, which is not the same as general medicine or general surgeries.
Yes.
Most of the trainers and trainee, they not get used to that. We are using CANMED, as you know, and Saudi ophthalmology, Saudi Council, starting to put that just only in the last year and in many programs. How we can use mix doing this, not only to load the resident with this multiple exams, because now the Saudi Council looking for exams coming from their side.
Yeah.
Not just only from the evaluation of the residency programs. And dealing with resident totally differ from the medical student. And
Yes.
I get used to saying that students.
Yes.
The resident totally differ.
Different.
And we expecting most of this evaluation, they have already been trained with them during their medical schools,
Right.
not on the residency programs.
Mhm.
So what do you think about your experience from applying this heavy
And,
types of
yeah.
evaluations?
I would just reflect briefly about the implementation of many clinical evaluation, workplace-based assessment in our institution. We didn't have it before. Our curriculum for undergraduate used to depend on long case. There was long case and there was in-training evaluation. But then we noticed that students either they score really, really high or really, really low, which is the real life of long case. We know that it depends on the chance of the student, and then they either pass or fail. And then we moved into workplace-based assessment. We introduced many clinical evaluation and case-based discussion, but before we introduce it, we train the trainers. So all the supervisors receive workshops on how to perform many clinical evaluation and how to perform case-based discussion and how to score it, how to give feedback. And despite this, we were facing problems. Some of your residents are our graduate, and they know that we were suffering with how to enhance the skills of the evaluator so that they are up to the required standard for what we wish. They are all good, but always you wish the best. So we had like a yearly, like 4 or 5 workshops for supervisors on how to perform our specific workplace-based assessment that we selected to implement. The second trick that is really important is to decide logistically how many you can do based on the number of supervisors that you have. You cannot load supervisor who is busy in the clinic and busy with all of his clinical work and tell him you need to do 10. He can't.
They requested only 2 for us per month.
Yes, so it has to be something logistically acceptable, so 2 is fine. And I think if just like skill enhancement, let's call it, on how to give feedback, how to do proper mini CX and case-based discussion. That's all what is required. It's really not that difficult. It's just introducing, even the resident needs to know how this is done, because they have to be the one looking for their supervisor and telling him that I have to go for this exam.
And
and
that's
you need
what
to
we
give
do.
me a
Usually
case.
we provide the resident with the mini 6 formats.
Yeah.
And he should, the one should give it to his
He should be
supervisor.
the one, so he should
And
initiate.
this is what we started in the last 2 months to give it, and they requested 2, at least 2 mini 6 to it. The CB yet started on, but I think will be the next. But I like your way that to have at least 5, 6 workshop
Yes.
yearly that to be done. Even
This is
so,
what we have done.
Yes.
This is what we have done, and I think it went on, and then people are training each others. So, and with supervision, and then maybe a correction workshop will happen every now and then. But at the beginning, it was workshops. It was a
And
training.
we have around 7 programs of ophthalmology in Saudi Arabia now. The only program that's starting to apply it, just Riyadh regions.
Riyadh,
To start with and to enhance it, as you said, once by once.
I think it's just enhancement. Everybody will have this observation skill for the student, for the resident or student or whatever, and everybody will have this ability to give feedback, but maybe just a fine-tuning on giving feedback, monitoring the feedback, secretarial work also, because these secretaries has to monitor the feedback and the recycle or the cycle of the feedback that the students or this residents was seen again to enhance this. And this is really sometimes a big deficiency if you implement feedback without this follow-up.
Nowadays, we are using, the monthly evaluations. At the end, you have to sit with your resident and to fill that format from it
and your form is really good.
Yeah.
Your form is really good.
And shall we in that include that the mini CX and CBD in that? Do you think that will be reliable or valid?
If there
instead just asking them, the secretary to collect it, to get it back, and to.
No, when you counsel a resident, he is finishing his rotation with you. You need to collect all the evidence, and we come back to the portfolio. This can be the portfolio, because the portfolio will be everything. So aggregation. So if you will counsel, put the portfolio in front of you and give the counseling.
We are using the FITA, which is the final end of training evaluations that now used in the. But till now it's not applied in the ophthalmology. What is the aim of that?
The final by the end of the program altogether?
Yes, usually they get
it's exactly the same aim of end of months. Okay. But it's the aggregation of the whole years. And this is used in Canada, used in most of the universities in America.
Is that helpful when you are going to get certificate of training, the logbook like? Because I think so this is a history of that candidate.
Well, this, the final end of training evaluation rating or this is, yes, whatever it is exactly a reflection of the portfolio. Because in this one, there will be everything and across the time. So the resident will keep on giving you things, and you will fill that one based on what you will fill it. No one will see one resident across all the training years. 4 or 5 for you? 5? 5 years? 4, okay. So across 4 years, I don't think there will be one evaluator who will see the resident for the 4 years altogether. The only way is to have this portfolio to be able to implement this end of training evaluation rating form.
All of this should be sent to the local committee, and local committee send it to the Saudi Council. Second year will be the same. Third year will be the same, and the fourth year will collect it together with logbook.
Okay, so this is portfolio.
Through the electronic
this is in another way a portfolio, because every year you are collecting all the evidence about one resident and send it. And then by the last year, by the end of 4th year, you are collecting all the 4-year evidence in one form, which is you are summarizing the performance of the resident across all the 4 years objectively. You are not just, yes, that guy, I have seen him, he is good. No, you are basing your evaluation based on solid evidence. And you know about it, and then you are performing your evaluation. So the benefit of this is the aggregation of the 4 years end of year evaluation you are doing it. But it's like systematic review. If you gather wrong data, you'll end up by big wrong data. So it depends on how you are collecting that. And that's why if you want to do it, and you are really keen to do it, which is a perfect idea, you have to go for portfolio, because you have the evidence. Mm.
higher. So I think so that could be used as an indicator to sit or not. Or if there is defect in the exams in the board, could be used or not. Is that this performance is excellent, it might help to this board.
I agree with you 100%, provided that the aggregated data is corrected properly. If the aggregated data about this resident is collected properly and you are sure about its accurateness, then go ahead, because you might give him a chance to go for the final and he doesn't deserve it, or vice versa. But if you are not sure about how it was implemented, then it's better not to use it, because as I told you, it's like collecting for systematic review or meta-analysis in a wrong way. So you are aggregating wrong data. You have to aggregate correct data. So, and if you want to implement it, you have to start now with resident R1. And that in 4 years' time, then you can use it. You cannot use it for the current residents. Yes?
Thank you, Dr. Hanan, for this simple presentation of how to assess the residents and students. I have just one comment. What is the value of doing the weekly quizzes and similar pre-tests to the reliability and of the mini CX and the oral exams? Could you clarify that with a little bit?
Weekly quizzes?
Yeah, just like an example of some of the pre-tests that we're doing. So we're doing pre-tests in our the
weekly quizzes.
Yeah, and is this like considered to be a pre-test for the mini CX, or where do you put this, and what is its value?
Okay. Mm.
So it's in addition to the mini CX, so it's still.
I can answer it in a very simple way.
Please.
There is no good assessment tool and there is no bad assessment tool. It is how you use that assessment tool. If you are implementing quizzes in a proper way, it will be of benefit. Why not? Can you do it? Do you have the logistic to do it? Go ahead and do it. Mind you that the student performance and the benefit, the educational impact of assessment on student performance, to some extent, it correlates with the number of assessment events to certain level. And then after that, you benefit nothing out of the extra assessment events that you are doing it. But doing something, there is no bad assessment tool. There is no old and a new assessment tool. All are good. Even the old assessment tool like long cases are good. And even I can see something in long cases, the organization skill and the organization of thoughts that we don't see in the new methods of assessment tools. The thing is practicality. Can you implement it or not? Do you have the tools to implement it? Do you have the logistic to implement it or not? Nothing bad and nothing good. Yeah, you need a cocktail of assessment, multiple assessment tool, multiple assessment events. So you have all of this in your curriculum. Your blueprint is really good. The thing is that how it will be implemented. The trick in the implementation rather than the design is perfect, but implemented properly. Yes, exactly.
Thank you.